All right, so I'm going to talk about another important topic that I sort of hinted at the other day, certainly a cause of acute chest pain, and an important one at that. I have no disclosures here. So basically the there's a tendency now to have all sorts of syndromes and combine things. So the acute aortic syndromes classically are aortic dissection, intramural hematoma, penetrating atherosclerotic ulcer. But some people will include larger things like trauma and aortic aneurysm rupture. Classically, they present with chest pain, which may or may not radiate to the back. That's the clinical scenario we've been aware of, although there's many variations on that theme as well. And they involve disruption into the aortic media as well. All are potentially serious and with differences in survival characteristics and imaging appearances. So I'm just going to talk a little bit about some technical things, and then we'll go into the classic acute aortic syndromes, and then talk about some of the other variants on the theme. And that will be a pretty good discussion. Okay, so let's talk about technique or technical possibilities. If you go back a good 40 or so years, angiography was, of course, the traditional way to diagnose that. I'm going to talk just briefly about chest radiography because I think there's a caveat in there. And then cross-sectional imaging, I'm mainly going to talk about MDCT, but we'll talk about MRI as well a little bit and brush on TEE. All right, so the chest radiograph, I bring this up because in another life I do some expert testimony, and so this is a bugaboo in the ER. I have a very low threshold for calling aortas tortuous. If it's normal, yeah, that's fine. But otherwise, I'll say mild descending aortic ectasia, and that's just out of an abundance of caution. The reality is very different. The chest radiograph is a largely useless technique for this diagnosis, but that's apparently not what certain people think. So it's normal to near normal in up to 40%. It's nonspecific in the rest. Do you ever see displaced intimal calcification? Send me a case if you see one. It's pretty unusual. Massive mediastinal widening, again, maybe can be nonspecific, can be for many different reasons. Aortic tortuosity, essentially useless. Now, this is, of course, titrated by age. If it's a 18-year-old, I would view it as different than in a typical patient who gets acute aortic syndrome in their 60s, 70s, whatever. That's a different story. But nonetheless, generally it's useless because those are the patients we see. They're in their 60s, and a lot of people in their 60s have tortuous aortas. I guess the one sign, if you have a baseline and the aortic contour itself has dramatically changed since the baseline, that might be something at least worthy of note. So that's the reality, in my view. However, out of abundance of caution, I'm much more conservative in terms of what I actually say. The technique, you can read here, but basically we try to, the thing I'll mention is we try to do ECG gating with these because of the pulsation artifact, which you can actually see at the bottom right, that can limit your assessment. And there have been times where others in the practice, let's say, have not done gating, and we've had to repeat it because we couldn't tell for certain about the pulsation artifact. We do reformats. I mean, those can be also helpful. I'll talk about more. That's more useful with TAVRs and so forth, but nonetheless, they can be useful. The IV bolus is, I think, very important. If it's not good enough, you can start to get factitious lines that look like intimal flaps, as in this case, and when you rebolus, you find that actually there's nothing there. Another example, ECG gating, a lot of pulsation. Would I have been worried about this? Perhaps not, for the reason that it looks like there are two adjacent aortas within the ascending aortic region, and I probably would have excused that as a pulsation artifact. But sometimes it can be very tricky. In this case, it was repeated, and you can see there was, again, no dissection here. All right, so let's talk briefly about some of the other techniques, in particular MRI. The advantage is that contrast is really optional. We don't usually need gadolinium. We may give it, but You don't need contrast. That's a big plus. You have several sequences, several shots at the same thing, whereas with CT, you really take your shot and you either have to rebolus or you're done. We can also look at the valve in a way that it's much harder on CT. The disadvantages, of course, are the standard ones that I think everybody's aware of. The technique, generally what we're going to do is a dark blood, bright blood approach. We may give gadolinium. It's probably not absolutely necessary. That's an MRI at the bottom. But we would use some sort of bright blood SSFP type sequence. All right, so with that as a little bit of a preamble, let us go and talk specifically about some of these syndromes. Of course, the classic one that we all grew up with is classic aortic dissection. But over time, this has gotten a lot more complicated. So this is a classification system that just came out in the last year or so. And you can see there are actually 5 different kinds of diseases or versions of this that come with intimal tears, ranging from number 1, which is the classic dissection, on down. So the ones that, of course, my arrows didn't come up here. The ones that I would probably focus on are going to be the class 1, class 2, which is intrarenal hematoma, and 4. The other ones are, well, we're going to talk about traumatic dissections. It's not really the same etiology. This is actually, I like this because this is the original description of an aortic dissection. I like the, memorably described as louder than the royal wind, which I think is rather descriptive. George II, by the way, was the King of England before our favorite George III, those of you who are from the United States. But this goes back. So this has been recognized for, more than 250 years at this point. They found a transverse fissure. There's your intimal flap. And that's what we find today. The etiology is an intimal tear. And that's plain and simple. And basically, generally, there's going to be rupture into the aortic wall. It's been thought in the past that they could arise in the wall and go the other way. We don't know for sure one way or the other. I doubt that's the case, actually. I think all of them essentially are due to rupture from the true lumen and into the wall and creating a true and a false lumen. That's probably what it is. And here's from our pathologist just an example of a rather striking example of an intimal tear with separation of the intima from the media and hemorrhage in there on the bottom. The risk factors, most common, are going to be hypertension/degenerative change, as we all know. Then there's a whole slew of other risk factors like the whole connective tissue disease spectrum from Marfan's to various other forms that you've run into. And interestingly, anything that kind of weakens collagen or causes any kind of necrosis of the media can cause problems. So pregnancy is a slight risk, aortic coarctation is a slight risk, and then obviously we ourselves are a slight risk. So those are some of the risk factors. I think everybody's familiar with the classification. Originally, the DeBakey, and more recently, the Stanford classification is used, type A versus type B. And this has significance just in terms of what you're going to do. Generally speaking, although, it's blurred now because of endografts, EVARs, or TVARs as we call them in the thorax. But classically type A was a surgical emergency and we treated type Bs, or they were treated medically. Now, of course, a lot of times everything's treated and there's an aortic graft and a TVAR in the descending aorta, so you've got a complete aortic treatment. The justification has always been, the real scary part of the type A's is that you can run into several complications, and those include stroke or syncope from head vessel occlusions, which Doppler would be good for checking out. Coronary artery occlusions, generally it's going to be the right coronary because of the way the flap occurs. Involvement of the aortic valve causing significant aortic regurgitation, necessitating replacement of that valve. And then finally, and most lethally, rupture into the pericardium. And that's something that want to be on the lookout for. You can have other ruptures, but they're less common. I've seen it rupture in the meson, the pleural space, and so forth. But it's going to be the one. This is, there'd been some uncertainty in how to classify arch dissections. So what do we call them now? This is something we looked at a while ago, and the best classification is probably to call an arch dissection a type B with arch involvement. Because in most cases, they're treated more like a type B with a EVAR or medical management with a stent extending into the arch. So that's how they're generally going to be labeled. Whereas type, in the original classification, the arch wasn't actually considered. We all know what they look like. CT is wonderful for nearly all of these things. So you can see your intimal flap. This is your classic sensitivity, as close to 100% as we can get. Specificity, quite similar. The true versus the false lumen. Generally, you can see, as I've said here, in the ascending aorta, the false lumen is anterior to the right, posterior to the left in the descending, and the reverse is true for the true lumen. And that's, of course, why the right coronary artery gets affected, because that's the false lumen, and that's the size. You can also see what are called cobwebs or the beak sign. The arrow is on the beak sign. That's a marker. Either one of these are a marker for the false lumen. So it looks like a little beak there, whereas the true lumen is sort of the opposite. And then you can also trace things. So the true lumen is going to connect to the ascending aorta, which isn't involved in a type B dissection. And this is actually the cobweb sign, just showing these little retained piece of tissue in the false lumen. And that's a sign, that's the so-called beak sign. So that's a marker also for the false lumen. The cobweb and the beak sign are markers for the false lumen. This just, again, shows you the benefits of reformats and the ability to trace the true lumen in this type B dissection. You can see very nicely, this is going to be the true lumen because it connects to the ascending aorta, which is unaffected. And then this is the false lumen. And you can do the same thing with this one. You can also, if you gate them, this is another benefit of gating, look for coronary involvement. And so you can see this was a question here. There's clearly a dissection flap on this volumetric image. We were able to show that they didn't want to do this by cath because this flap is very close to the left main. So we were able not only to show exactly where it was, but also to plot out the LAD in left main coronary artery in preparation for surgery. So that is another advantage. And then we can look for pericardial and mediastinal/pleural hemorrhage. And so there are examples of both. You can put Hounsfield units on it. If it's, it's hard to say that there's an exact number for Hounsfield units, but certainly if it's above 40, 45, 50 in that range, you're sure you're dealing with hemorrhage. If it gets a little less, you're a little less. It's more equivocal. So you have to be a little careful. MRI, if the main advantage contrast not required. And so if you can't do CT because of allergies or whatever, it's a pretty darn good technique. Of course, you've got to get them to the scanner. It has some disadvantage, but the imaging is actually quite robust. So we do that on occasion as well, but small occasion. And then it does have the advantage, as shown here, of showing aortic regurgitation, as shown by the arrow. You can possibly look at that by CT by looking at, if you get a good view of the aortic valve, lack of coaptation. That may be an indicator, and I think this shows it as well. You can see on a dynamic image that the valve leaflets are not closing properly. So this is a dissection with a little bit of aortic regurgitation. Just to mention transesophageal echocardiography, we rarely do this, partly because the specificity, it's prone to artifacts. The specificity is inconsistent. So that is probably a third choice. All right, let's talk about intramural hematoma. And this is an important one because it's essentially a dissection without a false lumen. Instead of a false lumen, you have bleeding into what would be the false lumen into the wall and propagation along the media, leading to a large area of thickening, wall thickening, which can be eccentric or sometimes it's actually circumferential. And so in this case, and we always get, and if I didn't mention it, basically we always get a pre-contrast scan to look for intramural hematoma. And so this is, and I showed it the other day. Let me see if I have, I have it here. This is post-contrast, and you'll notice the eccentric thickening and wall thickening here on the coronal. But you can also appreciate more decisively that there's this crescentic area of high contrast on the pre-contrast scan. That's a dead ringer in both of these. In the right-hand slide, you can appreciate that it's actually ascending and descending as well. So this is an intramural hematoma until proven otherwise in the acute chest pain setting. Could it be, vasculitis, I suppose, but in an acute chest pain setting, that's not what you want to be thinking about. MRI can do some of the same tricks. So you can see aortic wall thickening, intramural hematoma in this case. And depending on the age of the hemorrhage in the wall, on the right, you can actually see it turn bright as, depending on the age. If it's a little more subacute, you can see that. So if we look at intramural hematoma, the natural progression, about a third in this study at least some of them it actually can go away, believe it or not, it can heal. So it may not go on to a true dissection, but the other 2/3 either go on to dissection or just get wider with a persistent intramural hematoma. So in a sense, you have to think of this as being a dissection with the same natural history and the same treatment. They're a little more likely to watch these than a classic dissection, but nonetheless, it's something to worry about. In terms of the likelihood of problems, it depends a little bit on a couple factors. One is the hematoma thickness. So a hematoma thickness of 11 or above is said to be a higher risk factor, as is a larger aortic diameter. And of course, remember, dissection and aneurysm are two different things. Aneurysm is a descriptor of size, and dissection, of course, is an intimal flap. So they're not the same thing. Comparing a classic aortic dissection in the red arrow with an intramural hematoma in the green arrow, you can see that the IMH does have a slightly better diagnosis, but nonetheless, it's certainly not 100% survival rate. So you do have to treat it as a not quite as bad aortic dissection. So in a sense, it is similar. Now, what about other things? Well, penetrating aortic ulcer is a little more of a squirrely diagnosis, also more recently described than the others. And this is just an old angiogram showing what it looks like. It's most classic in the descending thoracic aorta because it is in that location. Chest pain radiating to the back is not unusual. And you're going to look for deep ulceration. There is a more formal definition based on pathology, the internal elastic lamina, but we don't really see that. So you're going to look for ulceration and perhaps a hemorrhage cap. I like to see some kind of hemorrhage cap before I will call this. So here's an example showing that penetration deep, still kind of not external enough to be a saccular aneurysm, although you can argue about that, I'll admit. And then there's a little bit of a non-fatty cap, which is hemorrhage around it. So it implies it's active, it's going on. And so I would call this a penetrating ulcer. Another example, same sort of thing. This is a bigger one. And there's some nomenclature discrepancy on this, but just showing, again, looks like an active process. You can see the cap around it. Is this a saccular aneurysm? We could have a discussion over a glass of wine, I suppose. Here's one that looks a little more like a classic penetrating ulcer. It's not really outside the confines of the wall. It's kind of internalized. And not only that, but if you look, it's not just got a hemorrhage cap, but it's going up and down. There's actually an associated IMH with this. So PAU, penetrating ulcer, and intramural hematoma have a relationship. And when you see a PAU, so some of the IMHs are not just rents, they're actually ulcers. And if there's an ulcer versus just a rent causing the IMH, that actually has a worse prognosis. So there's your IMH in the same patient. Then there are also little other outpouchings that you can see that these complicate things. So in the initial presentation, you can get what are called intramural blood pools within an IMH. And these little outpouchings with, so this would not be penetrating ulcers, no atherosclerosis or anything like that. This is a penetrating ulcer, I'm sorry, that's what I'm showing. The IMH looks like this. The IBP, it's intramural, all these symbols here are getting me. The intramural blood pool has this little, so I'm comparing the two. The PAU looks like an outpouching. The intramural blood pool often doesn't connect with the lumen and often has it's called the Chinese ring sign, this little intracostal vessel that comes out of it and often resolves as well. So it looks like it, but it's not in the same setting. And then there's also this ulcer-like projection, which can even be a little more like a PAU. So the one that's easiest to recognize is the one I showed you right here, this intramural blood pool. So that's the one I would keep an eye on. These are actually rare, but it would be in the setting of, you'll often see this, initially there'll be an intramural hematoma and this will appear later. So you'll know you have intramural hematoma. And then there are this is one of the rare things, this limited tear, which looks like similar to a penetrating ulcer, but it lacks the atherosclerosis. So that was actually a rare case of one of those 5 classifications that I showed you. The natural history of penetrating ulcer, after all that, is actually variable. And this is a study from some years ago that looked at a bunch of different lesions, and they found about 1/3 increased, and only a minority actually required intervention. But again, to make this diagnosis of penetrating ulcer, what I want to leave you with is the fact that it ought to have a little bit of a hematoma cap. But as I said at the outset, it is a squirrely diagnosis. All right, so then let me just talk a little bit about aortic aneurysm and trauma briefly. Aneurysm, I use a diameter of 5 centimeters. We see lots of patients that have 4.2 centimeters aortas in the ascending aorta. I don't call those aneurysms. I tend to call things ectasia, and this is semantic, but instead of pushing, let's say, scaring the patient, pushing the surgeon, I just use the term ectasia up to 5 centimeters. And after 5 centimeters, no question about it, that it's an aneurysm. We can have a discussion about that too. That's an interesting topic. Generally, they're asymptomatic. Certainly in their slightly growing phase, they can be fusiform, they can be saccular. Atherosclerosis is the most common cause by far in the thorax. They can be post-traumatic, as we're going to talk about briefly, and don't biopsy this. And this is just an example of fusiform and saccular. With volumetric imaging, more or less the same. I think the thing that if it's an ascending aortic aneurysm, you can determine whether it's marfanoid versus atherosclerosis. So classically, an atherosclerotic aneurysm has a sharply defined margin at the sinotubular junction. So my little drawing there, sinotubular junction is intact. Whereas here, the sinotubular junction is effaced. And that is a sign, the bottom one, of Marfan's. That would go with Marfan's. So that's the pear-shaped or tulip bulb or whatever sign of Marfan's, whereas the top one is an atherosclerotic appearance. So this is just an example. Intact here, this is an atherosclerotic aneurysm, okay? Whereas Marfan's, it's effaced. The sinotubular junction is effaced here. And so this is a connective tissue disease type, Ehlers-Danlos, Marfan's, et cetera. And that's just the volumetric image showing the same thing. Then you can also, of course, get saccular aneurysms, and those in many cases can be mycotic, or in some cases traumatic. So this is a mycotic aneurysm. And then you can, of course, get rupture. That, of course, we don't like to see. The risk is greatest if it's more than 6 centimeters, but obviously, as I mentioned, 5 centimeters is a bit of a cutoff. And if it's a Marfan's patient, it would even be less. So interval aortic involvement, enlargement, symptoms are also a very valuable sign. And we see this very well on CT. This is a different example, just showing a rupture. This is really pretty hard to miss, honestly. And then traumatic injury, most of these are going to be MVAs, falls, pedestrian struck kinds of things. The classic survivor is going to be at the aortic isthmus. And there are a couple theories, the shear theory and the osseous pinch theory, that have been proposed for why this happens. This is illustrating the osseous pinch theory, where the anterior complex and the spine crunch the aorta, causing it to be pinched and breaking or renting at the isthmus region. Now, of course, the direct signs are going to be an aortic contour abnormality or pseudoaneurysm. We're a major trauma center. We see quite a number of these. And it's not rare to see a short segment intimal flap, as the arrow is pointing to. You can use MPR and volumetric reconstructions to confirm it. So the direct sign is, again, shown by this. And here's just another example with hemorrhage around it. You can get this in atypical locations. So here's a rare, the most common location actually of all comers is at the root, but those patients do not survive. So what we usually see is the isthmus. But occasionally we see in the ascending aorta, and here's an example of a very striking ascending aortic TAI. Here's the volumetric reconstruction of same. And now we've become aware with CT of these minimal injuries that may not need intervention. Generally, we're going to stent a lot of these, and if worst case scenario, surgery. But nowadays, we run into these that have these minimal injuries. And in many cases, depending on the stability of the patient, they'll elect to follow them. So in this case, that's what happened. And indeed, it went away on follow-up. So there you go. And that can happen. So rather than intervening and leaving the patient with a permanent stent or surgery, that is an option. All right, and then just to mention other aortic things, post-procedural aorta, endograft leaks and so forth, surgery, just going to talk about. Types of endograft leaks. In the thorax, we often don't necessarily grade them the way they're done in the abdomen. We just say there's a leak because we do a lot of these, but you can see them. Here's what we would be a type 1 type of leak. And this is just a post-surgical aorta, and you can again appreciate this patient had an aortic surgery, and you can see that there's clearly extravasation here and a big hematoma around the ascending aorta. So that would be an example of a post-surgical aortic leak. And then just to finish by mentioning a couple of criteria. So you can see that the X-ray should be obtained not because it's diagnostic of aortic dissection, but because it is useful to rule out other things. That's the major reason. And then beyond that, much of what you're going to see is going to be chest CT with contrast and MRI following below that. And obviously, you can get the abdomen to see the full extent if it's going down to the iliacs as well. So, the core acute aortic syndromes, aortic dissection, intramural hematoma, and the very complicated penetrating aortic ulcer are understood to be related phenomena, interrelated phenomena, with little different variations. I think, as I mentioned, that it's very important to get a pre-contrast MT-CT, particularly in the context of intramural hematoma. And we categorize intramural hematoma A and B just like we do a classic aortic dissection, recognizing that there is a significant risk, albeit lower than a classic aortic dissection. And penetrating ulcer, as I showed you in a majority of cases, is managed conservatively. You can have mimics of it in the terms of the ulcer-like projections that I showed you and so forth. And then, of course, reformatting images. We want to use, in particular, ECG gating to especially in the ascending aorta, to try to rule out a dissection in that location, which we routinely do. Okay, so with that, I will thank you very much. A nice picture on a beautiful day of our hotel here. And I guess we have questions.
All right.
Thank you.